Hello, and welcome to the Opioids in Indian Country Learning Community Series. This is part 2 of our 4-part series. My name is Mardella Sunshine Costanzo, and I am the Broad and Focused Technical Assistance Task Lead for the SAMHSA Tribal TTA Center. On behalf of the Center's Contracting Officer Representative, Maureen Madison, and alternate Contracting Officer Representative Jan Dunbar Cooper, as well as our project co-directors Lori King and Gloria Guillory, I'd like to thank you for joining us today. In a few moments, we'll start our presentation in a good way, but first I'd like to take a moment to review our process. Today's webinar is being recorded, and a replay will be available in the near future. Because we are recording, all phone lines will be muted to minimize outside noise. But please do not hesitate to use the chat box for questions throughout the session. Today's PowerPoint is available for download on the lower right side of the screen. Just left click the file, and a download file button will appear at the bottom of the box. Clicking that button will automatically start the download. Finally, we appreciate you completing a brief participant survey that you'll receive after this session. This helps us better tailor our events to suit your needs. Now we would like to open our session in a good way. Doing this for us today, we have our Native Connections Technical Assistant, Grant Technical Assistant, Mr. Dave Braveheart.
Thank you, Mardella. And yes, it is an honor to be asked to do the opening here today. And I just wanted to say that I'm going to use our sacred breath to play the native flute. And I just wanted to share briefly that I'm inspired by my family, my children, but I'm also inspired by Neil deGrasse Tyson, who is an astrophysicist, American astronomer, who had mentioned that all of the air, the molecules in the air that our ancestors breathed in is now circling through all around us, and we are breathing that air as well. So just wanted to say that we use a sacred breath of our ancestors to render this flute song for all of you. all my relations, Madakiase.
Thank you, Dave. Our facilitator for today will be our colleague, SAMHSA Regional Administrator for Region 5, Captain Jeff Cody. At this time, I would like to turn the platform over to Captain Jeff Cody.
Thank you, Mardella. My name is Jeff Cody. I'm the Regional Administrator for Region 5, which is also the Bemidji area. This event was planned in conjunction with my good colleague, Chris Poole, at the Bemidji Area Health Service, the behavioral health consultant. For those of you who attended our first webinar, we discussed the Tribal Action Plan and how that could be a vehicle to help develop strategy and bring together the various partners and sectors of the community to have an impact against the opioid crisis. We also heard from Red Lake's naloxone program in terms of its effectiveness toward connecting people to treatment. Today's webinar series will focus on medication-assisted treatment. Our first presenter will be Commander Ted Hall, clinical pharmacist at the Ho-Chunk Nation. Following Ted, we will have the Saginaw Chippewa Tribal Court Healing to Wellness Program. Judge Shanahan and many of his staff will be presenting on the second part. But first, I'd like to hand it over to Ted, and he could talk about his program at Ho-Chunk. Go ahead, Ted. The floor is yours.
Thank you, sir. Thank you very much for the opportunity to join today. Thank you for all the efforts of everyone planning this series, and most especially thank you to all the participants that are joining us today and sharing this dialogue and exchange of ideas on how we can better help serve our communities and the individuals in those communities that are struggling with addiction and other mental health concerns. So as I said, my name is Ted Hall. I'm at the Ho-Chunk Nation. I'm the pharmacy director there. I've been there for going on 16 years now. I also am the clinical psychiatric pharmacist prescriber, so I'm on the medical staff as a non-physician provider, and my specialties are mental health and substance use disorders. So my intentions today are to give a really big overview, broad overview of our medically assisted treatment program, and share some of our successes. So to start off with disclosures, I have nothing to disclose, and the opinions and conclusions today are expressed primarily over myself and don't necessarily represent the views of the Department of Health and Human Services, U.S. Public Health Service, the Indian Health Service, or the Ho-Chunk Nation. So just a brief background about the Ho-Chunk Nation Health Department. The Ho-Chunk Behavioral Health and Primary Care Program serves a 16-county service delivery area, so we don't have a reservation area. We're spread across 16 counties in Wisconsin and 1 county in Minnesota, and they're spread pretty far apart at times. And of the 5,400 Ho-Chunk tribal members living in Wisconsin, 4,280 live in the 15 Wisconsin counties in our service delivery area. So we have a challenge where some of our tribal members do live outside of what's considered the CHSDA or our service delivery area, where Ho-Chunk Nation has put forth programs and funding to help support those that are living outside of that defined region. We operate 2 ambulatory care health clinics, one in Black River Falls, one which is in Jackson County, and one in the Baraboo area, which is in Sauk County. Those are about 80 miles apart. We also operate 4 satellite health offices, which are in Wittenberg, Nakusa, Toma, La Crosse, and each of those offices have behavioral health staff on site along with community health nursing staff. So the Ho-Chunk Nation, like I said, I've been there for going on 16 years, and we've worked in a very collaborative environment from the first day that I got there. The pharmacists were part of the medical staff. The medical providers were meeting with community health nurses to discuss their mutual pregnant moms and doing home care checks. So the Indian Health Service actually has a formal integrated care model called the Improving Patient Care Model, which you can go on IHS.gov and learn a little bit more about it. So the IHS Improving Patient Care Team Model is based on the Chronic Care Model by the McCall Institute for Healthcare Innovation. And as you can see on that slide there's some key elements to the integrated multidisciplinary patient care model. So the goals are individualized, patient and family-centered care. It's to ensure access to primary care for American Indians, Alaska Native people, provide consistent, high-quality care by healthcare teams. And the key term in there is consistent, to make sure that we're delivering the same high-quality services to every person who accesses our care, not just intermittently. So in 2013, the Ho-Chunk Nation, we formally engaged in the IPC-5. That was just the fifth cycle that they had run. And we developed some core teams, which included one primary care provider, one pharmacist, and one behavioral health provider. So that was the core team, meaning that they were just involved with the logistics of planning, organizing, facilitating meetings, whether it was patient meetings or also meetings in the clinic. The collaborative team is actually the entire health department staff. Everybody is part of the team in delivering high-quality services, including our ancillary staff that may not be providing direct services, but making sure that our rooms are sanitized and cleaned. So even our maintenance workers and also our patient registration staff are part of our team, and a crucial part because they're our first points of access to our services. So making sure that they are feel a part of the team and are aware of all of our processes. So I'll touch on that a little bit later, how we had to do a little bit of education there for some of our individuals to ensure that we're not creating barriers of care or potentially re-traumatizing patients who are already in addiction. So our objective is safe and effective management of pain syndromes and substance use disorders. So we started off with that focal point in the beginning, but that has evolved to include all conditions that anybody seeks services for. Now I realize that this is going to be very difficult to read, but I included a picture of the memorandum from 2014 that was really a milestone memorandum and point of origin for our program. So in the second paragraph it says, from the date of April 1st, 2014 forward, Commander Hall is authorized to administer and proceed with patient medical needs within the facility of House of Wellness. We started off at that one facility first, but now it's expanded to our whole health department, to include Dr. Amy DeLong, who is our medical director, oversight for tribally enrolled Ho-Chunk members, tribally enrolled Native Americans, Ho-Chunk Nation employees, and general public patients. And this was a key where we decided to open up this particular service to non-Native individuals who are not affiliated with the tribe in any way, because this is the opioid epidemic is a public health issue, and we realize that some of our tribal members who may be using drugs and alcohol are not necessarily only doing that with other tribal members. So in order to be able to best assist those individuals and support them, we want to make sure that we were going to be able to offer the same services to people who may be in relationships or living in the same household or even in the same social circles. And the key to that is they had to have a billable insurance. We tried to do the patient, the self-pay model, and it didn't work out quite well. So now basically if somebody is on Wisconsin Medicaid, they can access our medically assisted treatment. And then so from April 2014 to today, all of our medical providers offer the same services. So even though I may have been the one to pilot it and work out some of the protocol details, all of our providers and all of our clinics are very familiar with and administer the same services. So that was a key component. So just a really broad overview of what the program key components are. is it's an outpatient addiction program. So we realize that a lot of individuals cannot get the Vivitrol until they have gone through opioid detox and withdrawals. Most insurance plans, I don't think any insurance plans really will pay for inpatient opioid detox unless they have some other comorbid condition that's causing a medical threat. So what we've done is developed an outpatient addiction withdrawal supportive care treatment plan. So we basically prescribe medications that help target each of that person's withdrawal symptoms to help lessen the intensity of them so they can successfully detox. And then at their first negative urine drug screen for any opioids, we administer the long-acting naltrexone or Vivitrol injection. So a little clinical pearl is that we learned early on is that we have to make sure that we were testing for buprenorphine, which is Suboxone, and methadone. Those are synthetic opioids that won't typically show up on a routine drug screen. So there have been instances where they didn't self-report that they had been using these medications off the street. They came up with a negative urine drug screen for opioids, and then we precipitated withdrawal. So now these two, buprenorphine and methadone, are part of our standard urine drug screen panel. We provide psychoeducation to assist understanding of dependence as a biopsychosocial chronic brain disorder. So both in the behavioral health clinic and the medical clinic, we're doing a lot of education for individuals to understand why they may be feeling some physical effects or some of their behaviors, and to help with their retraining of their cognitive approaches to life stressors. So we work in a very highly integrated healthcare model. So once a month, we have 2 hours set aside where all of the medical providers, all of the behavioral health clinicians, the clinic nurses, the public health nurses, the pharmacists, the nutritionists, all meet, and we all present on our most complicated patients. And then each individual, each one of us, provides our perspectives of our touch points with that patient, and then we come up with a unified coordinated care plan around that individual, and then follow up with them at each visit. So I think that's one of the most important elements of any program for substance use disorders or even chronic care management. So realizing that we all have a unique component in treating the individual, the patients are fully supported from this multidisciplinary team that collaborates and engages with each other in communication. So part of our protocol, the individual must engage with AODA and mental health service counseling within 60 days. Sometimes they're getting referred to medical clinic from behavioral health and they're already engaged in services. Other times they're self-referring and getting on Vivitrol first, and then we're making sure that they engage in behavioral health services. So some of our individuals who are not affiliated with the tribe may not be eligible for services in our behavioral health division because of their service population policies. So my role as a provider then is to continue that conversation with them and provide them with local resources, with phone numbers, and have them engage. And we have releases of information signed so that I can call up at the local private counseling facility and say, is so-and-so following up with their AODA and mental health counseling. That's the only information I need to know. I don't need to go into treatment plans. But then I can document in my medical chart that there is that component being addressed. And I already spoke to our primary care behavioral health integrated model with extensive collaboration internally and with external providers and services as well. So I know that for the rest of the presentation, I'm going to focus on Vivitrol, and buprenorphine is a very effective medically assisted treatment modality and agent. So what we're looking to do as an extension of our Vivitrol program is some of our providers do have that special license to prescribe buprenorphine now. So we're going to be utilizing it in very special circumstances for pregnant women that are addicted to opioids. So having them on Subutex until delivery and then having a taper to Vivitrol, or individuals that are already in external Suboxone programs or illicitly using on the street, we would have them come on board, continue their Suboxone with a treatment plan of a rapid taper. And rapid is a loose term, meaning we're going to work with that individual, but that's get them to taper off of buprenorphine as quickly as they're able to possibly do so, and then 1 to 2 years of Vivitrol following on. But we're not going to be using it for induction or long-term maintenance. So for the Vivitrol program, which is a medically assisted treatment program for opioids and alcohol dependence, I've listed some of our program goals. And all of these goals are really just empowering the individual to get their life back, to get out from the chains of addiction. So, and that's our brochure. I took a long time and found this picture to have breaking free to a new life. So every individual that is struggling with addiction is imprisoned in their own body and mind. Sometimes they're not really that much in control of their own behaviors because of the addiction, wanting to avoid withdrawal, which is excruciating and drives them to continue to use even at the risk of death and a lot of other negative outcomes. So we assist the individual's ability to abstain from using alcohol and opioids, using Vivitrol, provide protection against the risk of overdose and death while an individual is on Vivitrol during that 28-day time frame. Even if they were to use opioids, they would not get the effect of the opioid. I'm going to have to reword that protection because now with the stronger agents of fentanyl and carfentanil, Vivitrol can be overridden and cause an overdose when those stronger agents are on board. But when it was just pure heroin, the amount of heroin an individual would need to use to overcome the Vivitrol would be a massive amount. But now in today's days and age with fentanyl and carfentanil being more common, it's a high risk for them to not engage in any kind of opioid use, even when they're on the Vivitrol. And again, teaching the skills to cope with cravings and life stressors, and that's done in behavioral health, but we do a little bit of that in primary care visits. And then treatment that is focused on the many pathways to recovery. So it's not one size fits all, and that's why we're incorporating buprenorphine in as a medically assisted treatment agent, but each individual is going to need a different level of resources or something that's going to work for them. So we assist the individuals with substance use disorders to integrate back into family systems with healthy relationships and healthy lifestyle. So taking the holistic approach and making sure that we're incorporating family into the process and helping them understand what addiction is. Connecting individuals to the personalized systems of care, so depending on what their resources are, whether there are tribal members or non-tribal community members, making sure that we're helping them maneuver the health systems to get them the resources that they need. And to me, the most important goal is to empower the individual to break free from the chains of addiction, regain control and freedom of choice, empower the individuals to reclaim their life that was stolen by addiction. So I'm going to move into some of our outcomes. What we did is developed an opioid dependence treatment inventory. It's a subjective 10-point Likert scale measurement that the first 6 questions address cravings, and then the last 6 questions will address the quality of life domains. The measures are perceived interference of opioid addiction over the previous month. So this is a subjective inventory. But we did adapt questions 7 through 12 from the evidence-based pain measurement tool of the brief pain inventory, the short form. And that has demonstrated in clinical trials reliability and validity across cultures and languages. So an example of what the inventory looks like is question 1 is, please rate your desire to use an opioid at its worst desire in the last month. So we can imagine at their first injection, they had been using for the previous month. So their subjective ratings are going to be on the higher level because they were actively still using or went through withdrawal on their own. And usually their worst desire or most intense desire was 8, 9, and 10. Then please rate your desire to use an opioid at its least desire in the last month. So, and it was its least intense. And then on average, over the last 30 days, what was your rating? Question number 4 is please rate how much desire to use an opioid are you having right at this moment. So right sitting in front of the provider. Question 5 is basically a rate your ability to abstain from using opioids in the last month. So 0 is they didn't use at all, or 10 they did use. So that's either a 0 or a 10. And then question number 6 is, in the last month, how much was your desire to use other addictive substances? Because we recognize that we may be able to address alcohol and opioids with Vivitrol, but then there's cross-addiction. They may substitute with other things like methamphetamine, marijuana, or other illicit substances. So we want to track that on the inventory so we can address it both in primary care as well as mental health to make sure that we're having them develop healthy life coping skills that is not just another agent, including some of the prescription medications that we use. So like I said, questions 7 through 12 were adapted from the brief pain inventory. So these are quality of life domains. In the last month, how much did opioid addiction interfere with your general activity? How much did opioid addiction interfere with your mood, interfere with your normal work or daily activities? How much did it interfere with your relationships, interfere with your sleep, and interfere with your enjoyment of life? So for 2 years, I was administering this at every injection for every single patient. So our internal review board allowed me to present on 11 cases at the Wisconsin Society of Addiction Medicine 2 years ago. So the results that I'm about to display now were what I was able to display at the Wisconsin Society of Addiction Medicine. So for those of you who haven't seen a radar graph before, I'll kind of explain it a little bit. It was a little confusing the first time I had seen one before, and I know the print is pretty small. So if you look around the outside of what looks like a spider web, you'll see the words worst, least, average, now, abstained, other substances, general activity, mood, normal daily activities, relationships, sleep, and enjoyment of life. So those are reflective of those 12 questions. And then, so the yellow line right in the center here is their results self-reported at their first injection. Or I'm sorry, that's the red line, is at their first injection. So individuals, on average, of the 11 cases, rated that their worst craving was a 7. And again, when we're using averages, there were some that rated 8, 9, and 10, and then some were rating, 4, 5, and 6. So that's where they came in at 7. And then at its least, they were still rating their most intense, their cravings at a 5. So between 5 and 7 is where their cravings were. And then as you can see in the quality of life domains at the left side of that scale there, you can see that opioid addiction interfered with their quality of life and their general activity, their mood, their normal activities. Relationships is usually, the average was a 9, so heavily influenced their relationships, their sleep, enjoyment, and overall enjoyment of life. So what we're seeing now is the change between injection 1, which is the red line, and then injection number 2, which is the yellow line. So we want all of this to collapse closer to 0, 0 meaning least or no interference. So even from injection number 1 to injection number 2, we see a drop from 7 to 3 in the worst cravings. And that's on average of just 11 individuals. From most of my patients, I see them saying that their cravings are almost eliminated from the first injection. And then as you can see, at their least it was a 0. On average, it was down around 1 and 2. But the part of the graph and the outcomes that I'm most interested in are how is it affecting your overall quality of life and enjoyment of life. So even, this is all abstinence and craving, but over here we see in their general activity, their mood, normal activities, relationships, all improved. Now this isn't solely because of the injection alone. At this time, people have a plan in place. They may not have seen their counselor yet, but they have a counseling session on board. So the medications do help calm down the physiological withdrawal symptoms and cravings of opioid addiction, but this is stuff that also, without even having significant amount of counseling time, also improved. So now on the next slide, we see the difference between injection 1. So that line looks exactly the same as before. Nothing changed. That's injection 1. But now the change from injection 1 to injection 4. So we see an even greater collapse in cravings, ability to abstain. And then if you look over here at the quality of life domains, they really collapsed in closer to 0, meaning that their overall enjoyment of life improved. Opioid dependence didn't interfere with their sleep. Their relationships improved. Their mood improved. Their general activity improved. So, and again, this is a small case study, just anecdotal data on 11 individuals, although I've tracked over 100 individuals that have very similar or exactly the same results. So, well, that's why we primarily focus on a taper from heroin to Vivitrol, or a taper from Suboxone, whether it's prescribed or illicitly used, to Vivitrol for a minimum of 1 to 2 years, because we know through neuroscience and fMRIs that and just general science of addiction today, that it can take anywhere from a year to 2 years for those higher functioning brain connections to really come back online, along with the psychosocial restructuring of individuals' life that has to happen to gain some stability for sustained recovery and sobriety. I know I went through that a little bit quick, and we have a great presentation following with many great presenters, so I can go ahead and address any questions at the end. I'm going to be on for the whole time, and just due to time, we'll go ahead and I'll field some questions at the end. So I'll turn it back over to Captain Cody. Thank you for your time and attention today.
Thank you, Ted. I think you articulated that with chronic health conditions, whether it is cardiovascular disease, diabetes, cancer, and addictions, the need for treatment. And treatment has both oftentimes a component that is medicine, as well as those psychosocial interventions. And I think the graph at the end there really showed a nice ability in terms of the functioning in life. So congratulations on a really successful implementation at the Ho-Chunk Nation. So for our next presenter, I'm going to hand this over to Judge Shanahan and his team. And they were going to talk about their Healing to Wellness program at the Saginaw Chippewa Nation. So, Judge, the floor is yours.
Thank you. And I'm assuming you can hear me okay. Is that correct?
I can.
Very good. Okay. Good afternoon, everyone. My name is Pat Shannon, and I'm the Chief Judge at Saginaw Chippewa Tribe in Mount Pleasant. And today, in front of you is our Healing to Wellness core team. But today we have with me is Joe Salmick, who is our coordinator, and also Aubrey Gross, a case manager. We've had a little bit of illness in the office, and Carol and our magistrate, and also Kathy Matthews, and I'll be filling in for those two today. But just a little bit about Healing to Wellness in the tribal court. As you know, well, this is a photograph of our staff, but Healing to Wellness is a part of our probationary function in the court. And just to give you a little background with me, I've been working in Indian country as a prosecutor, as a state prosecutor, tribal prosecutor, federal prosecutor, and since August 1980. So I'm a little old, but at the same time, I came back into the courtroom about 5 years ago, about 4 years ago, and found a completely different environment. We're now dealing with issues that I didn't see as a prosecutor, as a tribal prosecutor 15 years ago, 20 years ago. And now we're dealing not only with heroin, but also the prescription drugs and opioid abuse. And so this is, Healing to Wellness is a voluntary program. And you have to understand that in order to get into the program, you have to commit a crime, which is unfortunate at different levels. But and so we're working with the folks in a treatment mode, and viewing our viewing, we've referred to them as clients rather as defendants, and so they come into the program, and it's a multidisciplinary approach to working with each client who comes into the program. And certainly our mission is designed to reduce recidivism, family violence, and death. We're really in the business of keeping people alive anymore. And by leading the participants down the red road and by embracing cultural teachings of the seven grandfathers and the medicine wheel. And Joe Salmick will discuss that a little further down. And we hopefully provide our clients with a sense of pride and responsibility to themselves and their tribal community. As I mentioned to all of our clients, you're one of a very few group of people, and it's incumbent upon them ultimately when they reach sobriety and health that they help the other members of the community. If you noticed, I do have an education in public health, which has been extremely beneficial in my role here, not only as a prosecutor but also as a judge. But we tend to look at things in three different areas: in prevention, intervention, or interdiction, and also treatment. How do we prevent this? What's happened? This unleashing of by the pharmaceutical companies that's hit our communities. Certainly, 4 or 5 years ago, when we started this program, we had a very steep learning curve, and so some of the things we've done is I happen to be a member of the state Prescription Drug and Opioid Abuse Commission, and we're currently undergoing a number of recommendations for legislation and administrative rule change, and there's been numbers of them in the state. And I can tell you, from my experience, Michigan has been way behind when we look at other states in the surveillance of the problem and also the intervention of the problem and also treatment. Our court is a board member also, the Michigan Association of Treatment Courts. We established a FAN, or a Families Against Narcotics chapter, which is a grassroots approach to this. Also, we have been actively involved for well over a year in the Heroin Action Reduction Plan out of the Office of National Drug Control Policy. And so we, on a monthly basis, engage with those folks and see what's happening around the country. And I can assure you, we've seen everything just about, including carfentanil. And we've had deaths from carfentanil in this community. We're located in mid-Michigan and easy access to Flint, Saginaw, Lansing, Grand Rapids, and other areas. One thing that's interesting, working with the county sheriff, we do have a MAP program for Native and non-Native people in the county jail, which is pretty neat. Also, we do have a pretty good relationship with the University of Michigan School of Public Health, and they provided MAP training almost 2 years ago, and also have worked with us on some brain health training. And more recently, we are planning a forum for all 12 tribes in Michigan, and it'll be hosted in Mount Pleasant, and they're working closely with us. And also, as to the idea of interdiction or intervention, unfortunately, as I mentioned previously, you have to commit a crime to come into our program, and we're always trying to think, how do we get other members of the community in having access to these type of services? And so we're working on a few things. We're talking about establishing a juvenile court. I know some of you have that, and also maybe a prevention segment with our child protection department, and getting people in that way. And also, finally, treatment. We do have a behavioral health program here at the tribe, and we rely on them a great deal. We're in the midst of creating a tribal action plan. Certainly we have healing to wellness, and we continually review our inpatient, outpatient options and try to formulate the best practice we can. As a judge, and those of us others working in the court, we're just looking for remedies. how do we keep these people alive, keeping them safe, healthy, and keeping them alive. In Healing to Wellness, there are 4 phases, a cleansing phase, an action phase, the building phase, and also a maintenance phase. And we've had successes. You know, for those of you who have a treatment program, sometimes we only think of the failures, but we've had some real successes. And also, even maybe some of those who drop out of the program have learned some skills along the way. And so I can never really say we've had failures. Health professionals, we engage not only behavioral health, but the NIMCE health clinic, and we make sure that our folks get a dental evaluation, nutrition, along with a general physical prior to coming into the program. So we look at their behavioral health, mental health, medical health, also the social side of it, and also the spiritual side. And that is something the state courts are not able to do, is to bring all those services in. And so all of you who are working in Indian country, you're fortunate in that you have access to those type of services in your own communities, especially and including health, medical health, and also the spiritual side of it, which the state courts cannot use. So, and also, we can't totally legislate away from this. As I mentioned, I'm on a commission, and it's extremely difficult. It's like the Pandora's box was opened, and how do we get all of those things back in? There's lots of money involved, and there are a lot of complex causes to the problem that we have to deal with in a court function. And calling for the death penalty and that type of thing probably isn't going to work too well. There are some other serious underlying issues. As I mentioned earlier, Michigan, there's some data here from 2010 to 15. I wouldn't rely on it. I did receive something this morning from the state of Michigan that was sent out to the commission. It's probably the most up-to-date data regarding opioid and prescription drug abuse that I've seen that Michigan has been able to put together. I don't need to offend anyone, but it's probably the first time I've seen anything that's really been of any value that's been investigated. As I mentioned previously, we just have not done a good job in Michigan and to surveil and properly intervene and to treat these issues. Here's some more information. I'm not skeptical, but I would say it's probably not that accurate, but it's something that we have to work with. One thing that's interesting, our magistrate put this data together as the tribal member arraignments, because our magistrates do provide our magistrates do arraign the people that, and this is from June 17 through February 18th, and this thing, it says per cap, tribal members do receive some money, and I remember years ago I worked as a judge here, and on the days that payment went out, and this is when cocaine was very readily available in the major metropolitan areas, there were at least 2, if not 3, Detroit gangs that would come to the community and prey off the members, and so it seems like it continues on those days. And this number 10 is a full moon, so we always see a spike of some types of behavior, and then weekend, 56% of arrests involving prescription drug and opioid possession occurs on the weekend. So the other thing you have to keep in mind is that healing to wellness we will limit, and that's really by federal grant, is that we can't have assaultive people with an assaultive history. So we're dealing really with users and people who are in possession of the same, and not the street dealers. Our next speaker is Joe Salmick, a colleague of mine, and Joseph is a member of the Saginaw Chippewa tribe. And Joseph has a number of things to discuss with you. Joseph. Appreciate the opportunity to be with you this afternoon in a traditional way, in a good way. I'd like to go ahead and say Chimikanik, Nijinikas, Amekdodam, Saginaw Chippewa, Dojaba, Anishinaabe, and Dao. My spirit name is Big Turtle, and I'm from the Beaver Clan. We included a slide which gives an example of if there was a plane crash and 450 people passed away, you would expect something like that to lead the national news. Well, in this case, you're seeing deaths on a daily basis across the country. And the other slide talks about broken silos. And even in the Saginaw Chippewa Nation, it is a challenge to get a lot of departments working together, sharing information. I don't know if you've had that same thing happen in your community, but the idea is to break down the silos and to be able to go ahead and to share information, and that's what we're doing today. We do have some community outreach that we do, not only nationally but internationally, and Judge Shannon was able to share with some of his colleagues over in Ireland recently at the University of Limerick. One of the things we look at with Healing to Wellness is we are all in this together. Sometimes it's like rolling a rock up the hill, but you know, one person can't do this alone. One of the things I wanted to highlight in my portion of the presentation is if we put our culture first, we can go ahead and to more effectively communicate messages about the red road of recovery. And I believe communication is the key to engagement. And as a photojournalist with the Native American Journalists Association, I kind of switched careers after 23 years when I lost one of my friends to opioid addiction that I was working with, and then I contacted Judge Shannon, decided to get some skin in the game, and I became the Healing to Wellness Coordinator, where I get to oversee drug court. I get an opportunity to write about this not only in our tribal newspaper but for the Native American Journalists Association. So the importance of developing a media strategy, you are your best social marketer, and who better to tell your story? But to be open about the successes and the challenges you have within the program, we use what we call a SWOT analysis, looking at strengths, weaknesses, opportunities, and threats in order to internally evaluate your program. With the Healing to Wellness team, we make sure that everyone has a voice, not only the Saginaw Chippewa Tribal Police, but with our behavioral health program, child family services, right down to our tribal court. And it's always stronger when we get everyone together for those team meetings on Monday. I firmly believe to know the market that you're talking about and to be able to go ahead and to communicate directly with that market. That's why chapters like Family with Narcotics is so important. And I'm a firm believer that you can be the change you want to see in the world. If you could be the change you want to see in the world, you can be the change you want to see in your tribe, you can be the change you want to see in your community. One of the ways that we develop these changes within our Healing to Wellness program is we embrace the 4 paths of the Red Road. It's part of the White Bison Don Koyas teachings. And through that teaching, the true change must come from within. A lot of times with our clients, the conflict is going to precede the clarity. But to have that true change, there must be a vision. And along with that, having that vision of recovery,
there must be a great teaching. And a lot of times that's when our medicine people, our pipe carriers, our substance abuse therapists, our doctors, that's when those great teachings come in. And certainly there must be a healing forest, a community that's willing to go ahead and to embrace the healing that comes from walking that good path on the red road. I also believe the opposite of addiction is not sobriety. The opposite of addiction is connection. And that's one of the reasons that with our Healing to Wellness program, we encourage people to embrace lodge, cultural teachings, spiritual development with our native faith-based churches. I also included some statistics for Native Americans that show that we have a long way to go to educate society on how this is affecting Native country. But with your support and programs like this, we can do so. I also included that prescription opioids is killing about twice as many people in the U.S. as heroin, and the judge alluded to some of the things that are happening legislatively in Michigan to go ahead and to curb that. I also included some of the traditional teachings that are happening, a southwestern Alaska village, getting back to traditional law where they've banished people that are having challenges with substance abuse addiction. I also included some information on the dark web, and as we've talked about MAT, medically assisted treatment, we know that there are still some challenges with even professionals that exist within the government, like former Health and Human Service Secretary Tom Price, when he looked at medicated assisted treatment as substituting one opioid for another. And I just would like to make a pitch on behalf of Matt that we know it's evidence-based, we know it's best practices, and Indian Health Service, SAMHSA, including our practitioners here at NIMKI Clinic, we are behind medically assisted treatment. Let's go ahead and to get those clients the help they need. And one of the ways that we go ahead and to communicate with our culture, we embrace those 7 grandfather teachings, honesty, truth, wisdom, bravery, love, respect, humility. And the best way that those 7 grandfather teachings were imparted to me was after a sweat lodge teaching. I was on the banks of Lake Superior, and my elder, Mukatayanequet, reached down, grabbed a handful of sand on Lake Superior, and he went through, and as that sand was going through his hands, he said, "This is all we are. All we are grains of sand on Mother Earth, and we're only here for a short period of time." And he started talking about that grandfather humility, the grandfather that makes all of those other grandfathers work. And as long as we can embrace this teaching of humility, we're spiritual beings having a human experience. We're no greater than, we're no less than, we're all a child of the Creator, and we're here for a purpose. And through those 7 grandfather teachings, we can go ahead and to embrace that red road of recovery. And one of the ways that we can do that, we can let people know it's a good day to be Indigenous. We can be who we are and what we are as Native Americans. We kind of look at cultural approaches to medically assisted treatment. Western medicine being strengthened by these cultural approaches, and I would use the Powaggan, the sacred pipe, the sacred fire, eagle feathers, and some of our spiritual gifts that we were given by the Creator. And certainly a part of that with the Saginaw Chippewa tribe is embracing those 4 sacred medicines. And one of the things that we look at is what comes from the heart touches the heart. And when I think of medically assisted treatment, the medical part is the physicians and the medicine people. The assistance part comes from people like 12-step recovery sponsors, traditional elders, and the treatment part comes from therapy and lodge. And just like our Ho-Chunk brother mentioned, the medicine like Vivitrol is only as good as the treatment that follows the medicine. One of the traditional teachings that we look at from the Sacred Fire is we can be a storyteller, and remembering that everyone does have a story. When we sit at those lodge teachings, when we sit in those conference rooms, maybe we can agree to disagree without being disagreeable. And one of the teachings that I received from my grandmother Nokomis, it's nice to be important, but it is more important to be nice. And you will be known by how you treat people, especially your clients that are trying to embrace recovery. But the warmth of a sacred fire, as any firekeeper and pipe carrier knows, it has to start with a spark. And that's where it has to come from within. To be able to go ahead and to embrace your clients, and to know that if you can just get the fire of a spark going in their recovery, they can go ahead and to build that sacred fire within themselves. And part of that eagle feather teaching that we look at within our tribe, the eagle is a very majestic creature, but just like people, they can have that eagle-eye vision. And an eagle, a great hunter that can see for distances and be able to see their prey, but just like an eagle, sometimes we have an inability to focus on those things that are right up close to us. And that's why sometimes we need our elders, we need our therapists, we need adult supervision in our lives, and those teachers to come in to help us see the big picture, to help us to focus on those things that are right in front of us. And with that, I'd like to go ahead and to turn it over to my colleague, Aubrey Gross, who is our Healing to Wellness case manager. Chi McWetch.
Okay, thank you. I'm Aubrey Gross, and as Joe had stated, I am the case manager for the Healing to Wellness Court. My part of the presentation will be discussing effective community engagement through using an integrated healthcare model of case management. Integrated care is a systematic coordination of general and behavioral health care. And by combining mental health, substance abuse, and essential health care services, the best outcomes are achieved and have proven to be the most effective approach to caring for people with multiple healthcare needs. Our Healing to Wellness program is comprised of a dedicated team from several tribal and local departments, and through multidisciplinary efforts, services are offered that are specifically coordinated, managed, and comprehensive, and they include substance abuse treatment, judicial oversights, random drug screens, and any other services identified throughout the program based on individuals' needs. We are able to utilize our NIMKI medical clinic. Our clients are required to have updated medical, dental, and optical services, and all of those are available at the clinic. They also offer maternal infant health nurse, nutritionist. The clinic is able to offer Vivitrol assessments and administration. We encourage physical health, so the clients are able to use the NIMKI Fitness Center. The NIMKI pharmacy is also located within the clinic, and they are able to fill client prescriptions. The pharmacists offer education to our team as well as the clients within our court sessions. The pharmacy also contacts our case manager or coordinator to let us know if clients are filling any prescriptions that may be of question. NIMKI offers access to IHS funding. There's also referrals to outside services such as an addictionologist, liver specialist, neurologist, and any other services that may be available to clients outside of the clinic. We also work closely with our behavioral health department for all mental health services for clients. The team over there does assessments, which may include recommendations for individual and group sessions, individual intensive outpatient services as well. They offer substance use outreach services. They house the Residential Treatment Center and Supportive Living Center, which is based on the 12 steps and incorporates the cultural and traditional teachings as part of the healing process. Clients can also be referred to other treatment centers outside of the community within the state or out of the state. They offer drop-in groups, talking circles, SWAT lodges, acupuncture, and traditional healers. We also utilize other mental health providers in the community to best meet all of our client needs. Also part of our multidisciplinary efforts, other departments within the tribe are utilized that are non-health professionals to assist in improving clients' quality of life and overall well-being. We work closely with the Anishinaabe Child and Family Services Department. We have several clients who are involved with both our program and theirs, and the team members from ACFS are active in weekly team meetings. We work closely together to best serve the needs of the clients with the families and try to not overlap services and not overwhelm the clients. The ACFS department provides bus passes to program participants, including those that are not active ACFS participants, and they offer community service opportunities. ACFS offers a prevention department which allows clients to participate in parenting classes and have additional resources available based on the client's needs. Working with ACFS offers extra supervision and engagement, and the extra eyes may often catch red flags and bring them to the team meetings to help ensure that we are covering all gaps. In the last 6 months, we have had 2 families reunited and closed, and we have another one that will be occurring probably in the next 90 days. We also work with our Human Resources Department. Participants are required to work towards their education or employment in the 3rd and 4th phase of the program. We have the Anishinaabe Workforce Developer, part of our team, and he assists participants in seeking employment opportunities throughout the Saginaw Chippewa Indian Tribe. And in helping clients obtain employment, it helps establish self-worth and positivity for the clients. Part of the education component, they have to be working on one of the 2, whether it's education or employment. But we work with the Saginaw Chippewa Tribal College as well as the Mount Pleasant Public Schools Adult Education Program to help clients with GED, prep, and testing, and other higher education services. The majority of our clients have a 9th to 10th grade education level, and throughout the program and clients moving through the program, we have seen increased education levels overall among program participants. Part of the program is participants are required to complete 200 hours of community service, and part of our program, we do include attending cultural and community events towards community service hours. Examples would be seasonal feasts, educational workshops, and cultural teachings. But allowing these to count as community service hours allows for clients to rebuild the relationships with the community and strengthen their self. And by doing this, we're building a stronger, healthier, and more positive community. Right now, this is a little bit of our current healing to wellness data. I think some of the most important things to look at would be the age of first use. A lot of our clients are 10 to 13, and the majority of the highest level of education would be not having a GED or a high school diploma. And it's very possible that 2 of these things may be connected. But I think that is all that I have for my portion, and I am going to turn it back over to Judge Shannon.
Thank you, Aubrey. As usual, you did a wonderful job there, and I'm very fortunate to have a really good working group here. I have to fill in for Kathy Matthews. Kathy she's in court right now, so we have a number of cases that have to be finished up sentencing, and she's in there representing the probation department. Just a few things I want to go through, and then we'll take a break, I believe, and answer questions either for us or Commander Hall. But let me just go through this. I think many of you have worked in a court know that probation is a form of sentencing, and we look at certainly community service, fines, costs, work, behavioral health. But at the same time, when we talk about probation, the Healing to Wellness program, the probationers there are people who have been who have volunteered, have been convicted of either a controlled substance tribal crime, and are now in the probation area. These are some recent jail data looking at the percentage of tribal members who are in jail. We've been, over the last 3 or 4 years, trying to cut this down. It was higher than this. I don't have that data, but unfortunately, there are times that we have to rely upon the jail. Sometimes, however, just to keep people safe. As I mentioned earlier, one thing that we do is we do have a Vivitrol program in the jail working with community mental health and also the NIMKI Health Center. And so at least our people are given the opportunity to access medical-assisted treatment inside the jail, because what the sheriff and I had seen is that people were being released from jail and then using at the same level they were using when they went in, and many times it was fatal. And so what I learned the hard way is that abstinence kills. And so it was so good to hear from Commander Hall and also the training that we've received through SAMHSA and others about the need and the use of medical-assisted treatment. And now Carol is sick today. Carol is our magistrate, and she just put a few slides together regarding the magistrate. The magistrate in our court does all the arraignments, and so she's the first contact, and so she sees the behaviors of the people inside the court. You know, I do have to share with you, Carol, in the last year and a half has lost 2 children to prescription drug overdoses. And so it has impacted our lives, all of us here at Tribal Court. And so it's unfortunate she can't be here today. I don't know if I've ever met a person who's more just really involved in doing away with the death and the hurt that has resulted. But some of the things that Carol's identified, if some of our people are struggling, can't sit still, shaking, fidgeting, scratch. I like this, wiggling, and or docile, limp, sad, shoulders are down. But she evaluates them at that time, at the official, at the initial arraignment time. And these are some of the things that she has identified that's important. Listen to the defendants. Go off the record if necessary, and certainly offer them assistance and show that the court cares. You know, we're not there to beat people down. And also, we have to certainly collaborate. The court, as I mentioned, we get the issues in the court, where all we're doing is looking for remedies. How are we going to work with each one of our clients? And then, as Carol points out here, hope equals hold on, pain ends. I don't know if I've met another person who's experienced as much pain as Carol has, and so she's a wonderful addition. Certainly, the judicial role, we have to interact with the defendant, you know, and communicate with staff and be active and participate in the Healing to Wellness Court hearings and monitor the requirements. Every Monday morning we have Healing to Wellness, and this past Monday was just kind of a rough Monday for me because I had some administrative duties to do. But when I got in with our clients, it really made my day. Looking at our participants as you know, as equals, as humans here on this earth, trying to figure things out, has been an eye opener for me, and it's very healthy. Never lose your sense of humor. Isn't that true? You know, we try to laugh here because sometimes we don't deal with the best thing, and But anyway, thank you very much. I think, VC, that kind of leaves some time for answering questions. I'm sure Commander is going to have a lot of questions. So with that, I'll turn it back to you, Jeff, and VC.
Thank you, Judge Joan Aubrey. Thank you for the presentation. I think that, you really articulated clearly both the risks for individuals with opioid use disorder in terms of being in jail and the importance of MAT in terms of preventing death and overdose, as well as really talking about the role, how the judicial system, our law enforcement, are critical partners in terms of forging a path to recovery, and how the traditional culture of healing is certainly a critical component of that recovery, and how you've sort of incorporated it in with your medication-assisted treatment. Before we kind of proceed, I just want to say, from HHS standpoint, we are very supportive in terms of our grants and in terms of the use of medication-assisted treatment. I think it's, Joe made a good thing. How we talk about it and how we reference it is really important in our community. I know there's been a couple questions about there in terms of, enabling and substituting one drug for another, and sometimes that might, prohibit our ability to move medication-assisted treatment forward in our tribes and communities. But the department is firmly behind it, and we'll kind of talk about that a little bit more. I know there's some questions coming in. So Ted, did you want to take the first question that popped up?
Sure, I can. Thank you. So the question that came in for the audience is, can you describe any obstacles that were faced, if any, from other segments of your tribal community, i.e. law enforcement, courts, etc., regarding the implementation and success of medically assisted treatment services? I bring this up because I have encountered professionals from other communities who see MAT as another way of enabling clients who are addicted to opioids, just looking at some different strategies to overcome their perception of MAT as an effective treatment option. So certainly, right in the beginning, we have encountered it. We actually encountered it even internally, where we had certain providers that were not supportive because they said, and there were things like, I don't want those patients in our patient rooms or in our waiting rooms with our other patients. So a lot of education had to happen, even internally with our medical staff, and then rolling out from there. So what I alluded to before with our patient registration staff, who were our frontline face to our point of access in our clinics, is they sometimes had some negative perceptions and even created some barriers with making appointments because of what I like to call big behaviors. I don't like to say bad behaviors. Bad and good are arbitrary labels. And yes, there are some behaviors that people struggling with addiction will exhibit because of their discomfort or where they are just in their addiction or mental capacity. But the big behaviors of just being aggressive, assertive, a lot of what the magistrate had on her slides of assessing what does the person look like in front of you. So when I did a mini education to the patient registration staff of what a person is going through when they're going through withdrawals, and that's somebody's brother, sister, mother, father, I just saw a natural compassion ensue. And then they went from going to blocking appointments because they were frustrated at the person in front of them to going out of their way and going above and beyond, making appointments for those individuals and making sure that they got connected when they were ready to get some help. So yes, certainly from internal all the way out to the community, how we addressed it was just slowly education and just like as the judge said, number one, from compassion. Approaching this from compassion, realizing that we have an individual who is suffering from not only addiction, but probably some underlying mental health and trauma that we may not know about, and to treat everybody a little bit kindly, like they were our grandmother. So that was our approach, and it seemed to have worked, so we didn't have to really do much more than that.
Thank you, Ted. To the folks from Saginaw Chippewa, did you, in terms of implementing your program, have you encountered some resistance related to the promotion of medication-assisted treatment?
Yeah, and it's continual, and I can share it, and it's all an educational process. My fear along the way is that we just don't want to lose anybody, And we brought in MAT training 3 years ago, working with the University of Michigan School of Public Health, and health educators were provided CEUs, and we got a really good turnout. And also, it's on the Public Health Training Center at the University of Michigan if anyone wants to access that training and get CEUs for health educators, and also bringing in a speaker from U of M on brain health. And so I think you remember seeing the one slide of Sisyphus, the Greek who was pushing the rock up the hill, and every morning the rock would be down at the bottom of the hill. And as I've told Joseph and Aubrey and others, I said, we just have to find a way to get around those rocks and get up the hill. So it's a struggle. And even today, I ran into some opposition. From the law enforcement standpoint, I haven't really seen that here as much. And, you know, like I said, my background was law enforcement for 22 years. And I could talk law enforcement, but this is public health. And so, even on the Opioid and Prescription Drug Commission, there are representatives from law enforcement, and they get it. And I worry about our first responders out there who are bringing people back to life, and many of them probably don't like it. I don't know who would, but I would just say this. It is, that feeling is everywhere. It's in the healthcare industry, it's in the law enforcement area, it's in the court systems, and then also the other health providers too, that feeling that we're just exchanging one addiction for another, and it's hard to overcome. And so it's ongoing education and preparation of people. So, but like I said earlier, we're in the business of keeping people alive, and I'd rather see them on a Monday morning than read about them in the obituary.
Thank you, Judge. And Joe, I know you talked about the importance of story. And I think that something in our next series of webinar, we're actually going to talk about, the importance of a recovery story. And I think in terms of, promoting, we had talked about, Aubrey talked about, two people who are reunified with their families. I mean, I think there's these examples that we have that really are great, that they need to be shared and elevated in our community so others can see the effectiveness and some of the productive outcomes in terms of functioning, family reunification, and just overall benefit to our communities.
Well, when you look at things like Family Against Narcotics chapter, one of the strongest components of that is to be able to put a face on the situation. And for those that have lost people due to addiction, they have a story to tell, and it doesn't have to be that way for a lot of our communities. And, to go ahead and to give them a platform where it's a safe environment, where the medicine is there and the healers are there, where they can open and share some of the pain and grief, but also being able to get that release. And as long as we can let the clients know that they're not in this alone, and we can love them through it, I think that's the importance of the Nokomis teachings, being able to embrace those 7 grandfathers, and let our culture speak for itself. And when we put our culture first, it does speak volumes regardless of what tribe you're from.
Thank you, Joe. So, I'm just kind of looking at the chat box, and I know there's been quite a few questions and discussion about a tribal action plan. I believe that in the files for download, you can find information about a tribal action plan. I believe there's probably a recording from the first webinar that we did that talked about the tribal action plan from Lac de Flambeau, and how they utilized a GONA to help advance that tribal action plan, and I think the benefits to the tribe through that. And I know that BC could probably identify, in terms of folks who are interested in perhaps some potential technical assistance, what we can do in terms of assisting tribes with that from at least a SAMHSA perspective. So, BC, if you might want to put that in the chat box or something.
Yeah, I think folks have noticed Sarah Pearson has been responding to a few comments here and has taken a few emails. She is one of our TAP experts, if you will. She's worked on it for quite a bit. Our last session, we had our other colleague, Cipriano Lucario, on as well, who did a little more in-depth discussion about TAP and starting to develop it. So I hate to put her on the spot, but Sarah, if you're connected via phone, would you like to say a little bit about TAP development and maybe help guide people to some of our materials that we have? And I'm not quite sure Sarah's on a line, so let me just say that at the outset. Okay, she may not actually be on the phone line, but okay, she is not. What I would like to know, and I don't know if others are interested as well, but Joe, you know, I noticed in your presentation about Matt, you say that you integrate cultural aspects to it, and I didn't know if you could elaborate on that a little more. I know, of course, everybody's going to have different cultural tools that they use, but what are you using in your community that helps you to do that?
Well, let's use the example of genetic coding. You know, in Western medicine, you have 64 genetic codes as it relates to healing. You bring in ceremony, you bring in ritual, you bring in the healing medicine, you can have a multiplier effect of those genetic codes. And overall, you're trying to promote the good healing, and that's why we bring in the drum, we bring in the shaker, we bring in the smudge medicine, and you can actually get better outcomes when you're bringing this sort of thing into the emergency room, when you're bringing it over to the OR, when you have the medicine there available before the client gets a chance to go ahead and to meet with the doctors at the NIMCI clinic. And I get an opportunity to go ahead and to work with a lot of healthcare professionals just going ahead and showing that concept. And it's putting your faith first, it's putting the traditions first, and that's one of the ways that we can assist the medicine through our traditional teachings.
Great, thank you. I know someone has mentioned FAN, and Jeff has put a link in the chat box, but I want to say it out loud because folks won't see that link. It's www.familiesagainstnarcoticsaltogether.org. So that's got some information that we'll be able to use as well. And Judge Shannon is saying that FAN listens to the community. So maybe, Judge, would you like to tell us a little bit more about that program?
Yeah, and it's really important. Families Against Narcotics, another colleague of ours, Linda Davis, Judge Davis, is out of Macomb County, and they initiated this a few years ago, and it's just caught on like fire throughout the state. There's a program in Sault Ste. Marie, and I live in Sault Ste. Marie and practiced most of my career up there. And so if you don't know Michigan, it's in the Upper Peninsula. But in any event, the tribe here were the leaders to establish a FAN organization here, and it's grassroots, and it's for those people who are interested in to dealing with the this opioid and prescription abuse crisis that we're facing. One of the beautiful things, it was a few weeks ago, I went to Sault Ste. Marie and hosted a panel, and then also there was a showing of Chasing the Dragon, which is a federal movie, and it's very, very moving. And we did the same thing back here in Mount Pleasant, but what that did was to allow the community to speak. Our panel was made up of law enforcement providers, and so many times, like today, I think probably most of us are providers at some level. Either we're in the courtroom or behavioral health specialists or medical, and we're getting all the training, but it's this really is directed toward the community, to listen to the community as to what the needs are. So SAN is extremely important. I know if you access that website, the folks there they'll work with you. They just will work with. They're wonderful people, wonderful grassroots people, and quite frankly, I'm very proud that it started in Michigan or thereabouts, but it's taken off in Michigan because there was a hole as far as healthcare, as far as law enforcement. Now they do something called Hope Not Handcuffs, and they initiated something like that where people who can surrender themselves and the FAN volunteers will work to get them into treatment. And so there's this intervention and prevention and treatment model that they've adopted. So I would urge you, if you're interested, take a look at that.
Great, thank you. And we've got a comment from Kathy about reaching out and encouraging more participation to webinars and trainings like this. Jeff, I believe in addition to what we're doing, there's other information out there, correct?
Yeah, no, that's certainly something I know that we work closely with all of our federal partners, IHS and HRSA, to try to provide the information, whether it's like a webinar like this, or sometimes we could do more things sort of in person with other technical assistance to help build the capacity. I think that there's a theme. I mean, obviously we know that there's challenges. We know that there's certainly some. This is very impactful across the lifespan, but I think what we're hearing about is that there is hope, and that there is ways, and that there is solutions that many tribal communities are bringing forward, and the way we can help do more of those solutions that what would be fit appropriately for that tribe, we could see some productive results, and we can continue to forge recovery. So whatever way we can help support that, I think you would find some willing partners.
Well, keeping that in mind, we do have part 3 of this series coming up in May. Right now that is scheduled for May 16th, and we'll be talking a little more about the movement from treatment to recovery, and really specifically how tribes are integrating cultural practices and traditions into recovery. So it'll be the same time frame, 2:30 Eastern to 4 o'clock Eastern time, and keep an eye out for that. We do send out e-blasts letting folks know. Additionally, we're looking at a part 4 that would be a town hall. So when we send out, or if you register for that, you'll have an opportunity to ask questions. We're going to invite all of the folks who end up being part of the 3 sessions back just to answer your questions. So that is tentatively scheduled, for June 20th. Again, it would be at the same time. I want to mention that website one more time, www.familiesagainstnarcotics.com. And unless anyone has a final comment, we want to thank everyone for joining us. Jeff, did you have anything?
I do. Just thank you.